Okie dokie. Hello, hello. Good evening, everyone. Okay, looks like we're live on YouTube and about to be live on the other platform. Tonight I'm discussing chronic headaches, and I think it should be interesting. If you know someone with headaches, maybe share this with them. And I am Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And we work with patients you would consider it naturally who have headache disorders. And tonight I'm hoping to give you a little more understanding of the basis of headaches, how head pain is processed in your brain, and maybe some things to be aware of on blood testing or dietary factors that may be influencing your headache disorder. So, without further ado, I'm going to show you this picture. For all of you on Facebook, you can go back and watch this on YouTube. I did a screen-and-screen PowerPoint presentation. You can watch it live, and it will be posted later. So basically, here I have a diagram from the Principles of Neuroscience. As many of you know, I frequently attach images from this textbook. Why? Because they have great images, great graphics, and this is the Bible of neuroscience, so to speak. And so, relative to headaches and head pain is primarily transmitted through our trigeminal nerve. You may have heard of trigeminal neuralgia. Trigeminal neuralgia involves people who have horrible lancinating pain lots of times in one area of the trigeminal distribution, and you have three trigeminal distributions. You have the V1 as we term it, which comes basically down through here, involves the superior aspect of your orbit. Then we have the V2, which comes down through what you would refer to as the cheekbone area down into the lip. And then we have the V3, which is not at the angle of the jaw, but comes down right through here. If you've watched the movie Tommy Boy, I think when he was describing the pain in his face, I believe it was in the V3 distribution. So anyways, look at the diagram. That's the trigeminal nerve. So your trigeminal nerve has three primary nuclei within the brainstem. You have the principal sensory nucleus, and then you have the spinal trigeminal nucleus, and then you have a mesencephalic trigeminal nucleus. You can see all of that represented through here. So this basically the processing of pain from your head extends largely throughout your brainstem, and it goes down into the top part of your neck. So that's important because you may hear me say all pain from the head is processed in the neck, which I'm going to show you here in a second. And this is the reason why a lot of people go and they get adjusted, or they have acupuncture to their neck, or they have cranial work done to their neck, and craniosacral, but they get cranial work done to their head, and then all of a sudden their headaches improve, and it makes you wonder, well, did they have a bone out of place? Was a bone out of place in my neck causing my migraines? Or gosh, were one of my cranial bones, have they shifted? Was that causing my migraines? Really what we're finding is that when we do mechanical therapies to the head or neck, you can influence the input from the joints into your cervical spinal cord, the signals, so to speak, and that can help to dampen pain, a la Botox. So a lot of migraineurs now are getting Botox. What is Botox? Basically, it paralyzes your muscles, and neurologists are now injecting Botox into different areas of the face and the head and the neck, and we're finding that relieving that muscle tension, so to speak, that can have profound impacts on headaches. So that's a representation of the trigeminal nucleus, and I just wanted to answer a few questions. Great to see you again too. Oh, great. All right, so we're going to give you the details. Perfect. Now, in terms of understanding pain processing, and I don't know quite how deep to go, and I think I'll just pause right there just to give the overview again relative to headaches. What's really important for you to know is that thyroid disorders are very important in the genesis of headaches, as is insulin resistance, as are mitochondrial problems. So for those of you interested in the functional world, Thyroid's important, blood sugar is important, as are the mitochondria. I'm going to get to all of that, but you kind of have to understand this basic physiology before I go into that. So relative to pain processing, you need to know that just because you have pain receptors firing doesn't mean that your brain is experiencing pain. Pain is not a one-to-one phenomena. And we've been ingrained within, I don't know, our medical system or society that if I'm having pain, there is absolutely something wrong in my tissues. And sometimes there absolutely is. If you whatever, you stab yourself with a fork or something, yeah, you're going to have a noxious event, as it's termed. The pain neurons, which are really not pain neurons until it gets to your brain, but nociceptive neurons are going to fire, and then your brain's going to perceive, oh my gosh, I have a fork sticking in my hand. Well, it's also important to know that we have these nociceptive fibers, as they're termed. Think of them as pain fibers, but it's not pain until it reaches your brain. These nociceptive fibers are firing all the time, and your brain is creating chemicals that drown out those signals. What are some of those chemicals? Serotonin, norepinephrine, opioids. Our brain produces opioids. That's how we discovered the whole opioid issue. So your brain is producing these chemicals all the time to help shut off pain. That's important because other factors can help to drown out the pain, like joint motion. So really good joint motion and input from our joints as well as our muscle spindles send very rapid signals that have been found to shut off what's referred to as the pain gate. So think of a train track, and you have two train tracks right next to each other. They're parallel. And then you have that switch, so to speak, where one train can go over to the other train tracks, and we have a switch that facilitates that. Well, you have the exact same type of phenomena for pain. So when your joints are working really well and your muscle spindles are sending great signals, and it's sending a very fastly frequency neurological signals, that's the best way to say it, then we have the probability of shutting off pain, which is really important. It's even more important for headache sufferers because if you're getting really good input from your cervical joints, then that can help to shut off pain from your head. And we had a question posed by a really nice individual on Facebook talking about, well, I have atlantoaxial instability or craniocervical instability, and I have horrible headaches. Well, what is happening is, here's your brain. Your brain sits in your skull. If your skull is not stable on the top part of your neck, well, then what is that doing? That's producing probably some abnormal joint input into the top part of your cervical spinal cord. So the probability of shutting off pain from the head is probably lower because of that. So that's the basic premise. All right, deep breath. I hope that all of you are getting it. If this is making sense, give me a thumbs up or something. I would love the feedback. Okay, so now you basically understand that pain from your head is sent through the trigeminal system. That's basically what you need to know. The trigeminal system for pain descends down into at least the first three levels of your cervical spinal cord, down to about the C3 level, and then it crosses over. As you can see in this diagram, we have signals crossing over, and then it goes up to the other side. Joint input from your neck and muscle spindle input is really, really, really important for shutting off pain. Okay, awesome. Looks like it's making sense. Okay. So then we have the whole phenomena of, let's talk about migraines. So migraines consist of individuals who may have an aura, they may not have an aura. What is an aura? An aura lots of times is a visual event. It's a visual disturbance. People may see like lightning bolts in their vision. It can be non-visual. Maybe they have a change in speech, or they have a change in motor function, or they're not able to write as well. So these are changes in neurological function before a headache. They can actually occur during a headache, or they can occur by themselves without a headache occurring at all. So that is an aura. Now, not all patients who have migraines have an aura. What is a migraine? A migraine is this headache that comes on. There's typically throbbing, maybe one side, maybe both sides. And the throbbing headache is associated with light and sound sensitivity, frequently associated with nausea, and a worsening of the headache with motion. So the classic case of a migrainer is that well, there's classic migraines and common migraines. We won't get into that. Classic is basically with the aura, common is without the aura. But when we think of a migraine patient, what do we think? We think of somebody lying in a dark room with the door closed. That's what they need because the light and the sound bother them, motion bothers them. A migraine basically inhibits one's ability to do their activities of daily living. So that throbbing clearly would suggest to you, well, something is going on in the brain involving blood flow. So somehow there is a disturbance of blood flow for the migraine patient. And I attached this diagram here where you can see that we have the prodromal phase. So leading up to the headache, even before, let's say, an aura occurs, a migrainer may have appetite cravings. They may be tired and yawning. They may have heightened perception, like things are just a little more sensitive. They may notice fluid retention in parts of their body. And then once they develop the headache, then they may have nausea and vomiting. They're sleepy. They have to go to sleep in a dark room. Again, everything is bothering them, smells, sounds, noises. And then as the migraine resolves, they might possibly vomit. Lots of times people vomit and they feel better. They go into a deep sleep. And then they may not be hungry as they start to feel better. And then they're still, they may be sensitive to light and noise. And then they come into a normal period. So that's kind of the progression of migraines. And some people have migraines once a month. They may have it around their menstrual periods. They may have it around ovulation. They may have migraines literally more than 15 days a month in the chronic severe form. Sorry, I have something in my eye. So this schema or figure is, well, these are good questions. I'll come back to these. This figure is demonstrating changes in blood flow for migraine patients. Basically, what we're finding is that there can be increased perfusion in certain areas of the brain leading up to a headache in the premonitory phase of the migraine attack, the premonitory phase. And we see that a lot of these areas that are getting more blood involve, like the hypothalamus, they involve the brainstem. Remember me talking about opioids, the periaqueductal gray here is one of the critical areas involved. The dorsal pons is involved. If they have nausea, then the medulla is involved, where our emetic centers are located. And then this diagram basically represented that the trigeminal nucleus, which I talked about, the trigeminal nucleus, which involves pain, they can see that it's getting more activity. It's more sensitive leading up to a migraine attack, which is super interesting. So if you want to pause the YouTube video for all the Facebookers, you can switch over to YouTube later and look at this diagram. It's so interesting that, in essence, the activity of the trigeminal nucleus, our pain-sensing nucleus in the brain, starts increasing in a linear fashion until the headache occurs. So it's almost as though they can predict when the migraine is going to occur. The person may not feel it, but they can predict when the migraine is going to occur based on the activity of that nucleus from a functional MRI standpoint. So this diagram really represents it. So simply when a migrainer is not having a migraine headache, do they have more, less, or the same amount of blood flow in their brain as someone without migraine headaches? And basically they have the same amount of blood flow in their brain when they're not having migraine headaches versus someone who doesn't have migraines. Their blood vessels probably are very reactive to different circumstances. So bright lights, stress, alcohol changes, caffeine changes, foods can make their blood vessels more reactive. But basically the amount of blood going into a migrainer's brain versus a normal control when the migrainer is not having headaches is the same. However, once the migrainer goes into the aura phase, there seems to be, the general consensus, a lack of blood flow perfusing through the gray matter. So in the aura phase, there seems to be a lack of blood flow. And then there's this reactive increase in blood flow, which we call hyperperfusion, that seems to happen after the headache starts and keeps going, maybe even after the headache ends. So it's not a one-to-one, but it seems to be, and you can see this diagram, that basically the aura phase is associated with hypoperfusion. Then the headache starts. Then after the headache starts, we get this hyperperfusion. And then eventually as the headache goes away, then we still have hyperperfusion, and then we have normal cerebral blood flow. So that's really important. I think anybody with migraines should know this. This is the culmination of tons of research for lots of years on this topic, and they basically synthesized in this study. Where was this published? This is a review article out of the Journal of Cerebral Blood Flow and Metabolism, 2019. So this is pretty much as new as we know, and this should help those of you who have migraines to kind of understand what's going on. When people have really severe migraines, what do? They go to the emergency room and they get the quote-unquote migraine cocktail. One of the ingredients in the migraine cocktail is dihydroergotamine, if I remember. Ergot derivatives basically cause the blood vessels to constrict down so that we stop having this hyperperfusion event in the brain, and that's thought maybe what we're feeling in terms of the pulsating. Some people say yes, some people say no. And then for those of you who have an aura, which is some people say around a third of migraine patients, the aura, they actually refer to it as what's called cortical spreading depression. So it's literally like a shock wave. Think of dropping a rock in a pond. And when you drop a rock in a pond, then you get a ripple, and then you get a ripple, and you get a bigger ripple. So that rippling effect in the pond is referred to as cortical spreading depression. It's literally like a shock wave of depression that spreads throughout the brain. And I don't know if you've heard of the G lymphatic system, but the glymphatic flow is this lymphatic system they recently discovered in the brain. And when people have cortical spreading depression, basically there's impaired flow out of perivascular spaces into the G lymphatic system. And maybe that's part of the whole pain process too that eventually develops, maybe not. Now this article is fantastic. This is out of Current Pain and Headache Reports. And the title is Migraine Primarily a Metabolo-Endocrine Disorder? Sorry, I can't talk tonight. It's late. It's 8 o'clock before Thanksgiving. I'll say it again. Is migraine primarily a metabolo-endocrine disorder? Super important. So they basically say all the clinical studies that use the oral glucose tolerance test to examine insulin sensitivity found that after glucose load, there is in migraine patients a significant increase of both plasmatic insulin and glucose concentrations in comparison to controls. What does this mean? Basically means that migraine patients are much more likely to be insulin resistant. Doesn't mean they're diabetic. There's actually not a correlation between type 1 diabetes and migraines, but migraine patients tend to be insulin resistant. So when migraine patients eat carbs, so tomorrow is Thanksgiving, so what's going to happen? You know, we're going to have 12 of those delicious little hot rolls, and you're going to have a big serving of mashed potatoes. There's going to be tons of carbs. And when someone consumes carbohydrates who's insulin resistant, they're going to produce more insulin than they maybe would have 20 years ago, but still that amount of insulin produced is typically not enough to control blood sugar in the right range. So I'll kind of illustrate a little graph. Blood sugar should go up and it should plateau because insulin should go up at an equivalent level and plateau with the sugar. However, if we're insulin resistant, what happens? Sugar goes up, it goes up, goes up, goes up. Not quite diabetic high, but it goes up, and then it may do this. We have a roller coaster effect. And that whole time, insulin went up too, and insulin was way higher than it should have been. But biochemically, that's very stressful for our body. There's a lot of inflammatory effects from that. There are effects in terms of antioxidant function, and I'll get to all that. But you need to know, and this is a review article in 2018 out of Current Pain and Headache Reports. This is one of the top headache journals where they're saying that basically all these studies are showing headache patients have impaired insulin function. They're not as insulin sensitive. They're insulin resistant. So from a functional standpoint in functional neurology, what do? We want to correct that insulin resistance. What does insulin resistance relate to? It relates to gut bacterial dysmetabolism, dysbiosis, absorbing pieces of gram-negative bacteria we shouldn't, which absorb excessively into the liver, which then activates inflammatory pathways and also activates an insulin-resistant phenomena within our body. So that's important. And then they go on to, let me see here. You can read the rest. But they also point out that there's a huge association with thyroid disorders. Taken together, the results of these studies suggest that migraine and hypothyroidism are linked by a bidirectional relationship. Both genetic and immune mechanisms may explain this association. So those of you who watch me all the time, what am I talking about? Hashimoto's thyroiditis, where the immune system attacks the thyroid. Well, it seems that those who have migraines have a huge probability of developing a thyroid disorder. And the thought is, well, why is that occurring? Well, maybe these individuals, their immune system was attacking the thyroid when they were developing the migraine disorder, and lots of times it can take a while, it can take years for ultimately the thyroid to go low in terms of its function. So if you have friends with migraines, make sure they're screened with an oral glucose tolerance test. It's much more involved than the standard blood sugar test, and make sure that they're getting a detailed thyroid panel. Go back and watch my thyroid broadcast that I did recently. Okay, I'm going to pause there, just look at some questions. Are ocular migraines related at all to the more common headache migraine? And I would say yes, they are, and it's probably a more localized version involving the occipital cortex. I can't quote a study on that, but that's what I remember from the reading that I've done on this. Okay, all right, and I'm glad that this is resonating and it's helping. Okay, fantastic. Thank you all for joining too. I appreciate it. Now, this is a great article out of Nature Reviews Neurology. So, like, Nature's and the Nature journals are very high, of very high importance in the scientific world. So, when you see something out of Nature Reviews or the journal Nature, you want to pay attention to it. This article says the metabolic phase of migraine, from pathophysiology to treatment. And this is a great diagram for those of you who want to pause the YouTube video. Here they show glucose coming basically into the brain, how it's going to be absorbed into neurons, how this glucose is going to be processed within the mitochondria. What are the mitochondria? The mitochondria make energy. Your mitochondria, think of them as a dam. Here in the Reno area, we have Boca. I think we have the Boca Dam. We have Stampede down in Vegas. You have the infamous Hoover Dam in Sacramento. You have the Folsom Dam. A dam works by having a wall that then water can go through turbines to make energy. If you don't have a good wall, then you have a YouTube video, right? And where we're all watching late at night, watching these dams fail. Well, that water going through the dam and the holes does not facilitate good energy production. So if your mitochondria don't have a good mitochondrial membrane, or they don't have the turbines within them, they're not going to be able to make energy. If you can't make energy, then you can't perhaps have good systems involved in your brain to say, hey, we're accumulating inflammation in this part of the brain, and we need to get blood flow to flush it out. So it's thought that the insulin resistance that I mentioned that are seen in migraine patients, or mitochondrial dynamics that are not correct, because when they look at genetic studies on migraines, they see that a lot of the genetics for migraines actually involve energy metabolism in the brain. So there's something wrong in the mitochondrial chain that's not allowing energy to be produced in the neurons to then facilitate these signals to say, hey, we have accumulation of inflammatory mediators in our brain. We need to get this junk out. What are the current migraine medications you're seeing on television? They're drugs like Aimovig, and Emgality is one, and there are a couple others, and they are immune cells. They're like immune Pac-Man to an inflammatory mediator called CGRP. And so these are immune cells that kill CGRP. But it raises a question, is that fanning the smoke when the underlying fire is, why are we accumulating CGRP so excessively in the brain of a migraine patient? It's probably because the energy metabolism dynamics are completely skewed and not correct. So this is the reason why mitochondrial support can be important for migraine patients. It's actually becoming one of the more commonly utilized medical interventions actually in neurology clinics and migraine clinics. It's basically giving people supplements, not always medications, to help them with their migraine headaches. Even Topamax works on the mitochondria. Topamax is a common migraine med. These are the key points, and that's pretty much it. So to summarize, pain from the head is processed in your neck. The pain that descends down into your neck has the ability to be modulated by input from your cervical joints and from your muscles. This is why chiropractic treatments, physical therapy treatments, acupuncture treatments, craniosacral treatments can have an impact on headaches of all diagnoses, not just cervicogenic headaches. This is why Botox likely helps a lot of patients with headaches. From there, we know if you have abnormal biomechanical relationships in your neck, like maybe you have some herniated discs up high, or you have abnormal joint movement, or you have atlantoaxial instability, that your probability of shutting off head pain may be a little bit reduced because of that. And that's a reason why we at least have to acknowledge and maybe work with some biomechanics in the cervical spine for headache patients. Then we also know that migraines involve changes in blood flow in the brain, and those changes in blood flow in the brain can be modulated with medications. I didn't even go into that, but most of you have migraines, have tried medications, and you're looking for other alternatives. And so those other alternatives may relate to thyroid disorders of some shape or form, insulin resistance, because when you're insulin resistant, you're not processing energy correctly in your brain, and that can have a profound impact on antioxidant levels and inflammatory levels and signaling to get inflammatory mediators out of your brain. And you may have mitochondrial dynamics that are not correct as well. So those are features I recommend you look into. I hope this made sense. Send me your questions, and if you want me to do follow-up videos on headaches, I'd be happy to. In terms of chronic headaches, I mean, when you look at the International Classification of Headache Disorders, it's literally pages and pages and pages, single space, of diagnoses for headaches. So there are a bazillion different possibilities for the genesis of a primary headache disorder or a secondary headache disorder. But hopefully this maybe gave you some insight into the underlying pathophysiology. All right, so cool. I'm glad this helped. You all have a wonderful weekend, a wonderful holiday weekend. Be safe, stay well, and I will see you all next week. Okay.